This is my disclosures. I was asked to talk about massive and submassive PE, and following since 2008, now a good 7 years, we have guidelines that call for IV thrombolysis and surgical embolectomy for massive PE, and consideration of endovascular interventions. And for submassive PE, the waters are not clear, and they call for consideration of IV thrombolysis. I want in these 10 minutes make a point to say that endovascular interventions should become the mainstay. They have become the main therapy for both massive and submassive PE. Why am I saying this? Because there's a bunch of papers that you can criticize each one by one in the methodology, but in combination give you a pretty good idea that not resolving the RV dysfunction of a patient who comes to your hospital is bad for their health. Number one, the mortality has been seen to be 11 times worse when that patient has an index of pulmonary obstruction, which is a radiology index, but an index nevertheless of more than 40%. This patient that you don't resolve the RV dysfunction at discharge has 8 more times of having recurrent PE than if you resolve it. A patient with submassive PE a year after is going to have 40 that you actually release from the hospital with RV dysfunction is going to have chronic pulmonary hypertension, almost half of them. If you find hypokinesia of the right ventricle on the first echocardiogram, this patient is going to have a 57% higher mortality at 3 months, even though these patients came to your hospital with normal blood pressure and normal pulse, what we call compensated shock, but they did have abnormal RV hemodynamics on your echo. We know that anticoagulation alone will prevent propagation of the clot, but will not dissolve the clot. And what is being shown is that anticoagulation alone, when compared with systemic thrombolysis can reserve the RV dilatation faster within 24 hours usually of therapy. So IV fibrinolysis is good, we have it available. It increases right ventricular function, increases pulmonary perfusion, and diminishes recurrent PE, but at a high cost. And that cost is bleeding complications that have been reported up to 20%. 1 out of 5 patients are going to bleed, and importantly, up to 3% intracranial bleeds that are often fatal. So several devices have been described, like Angiojet, like GuardDog, but my goal is to show you what we do in our practice in Tucson, and this is the use of ultrasound accelerated thrombolysis. This is a video that shows how a regular thrombolysis catheter with side holes, when you connect that catheter to ultrasound applies mechanical waves to that clot, accelerating the penetration of the drug. As you can see there, is mechanically applying waves to that column of water, accelerating the thrombolysis process. So since 2010, we have now 5 years. In 2010, Dr. Lin, Dr. Engelhardt in Louisiana, Dr. Shah, Dr. Amangwa, and others start showing case reports of the benefit of this technology in PE. And more recently, we have now a little better designed trials, such as the Ultima trial, which is your trial held in Europe, and the Seattle trial 1 and 2 held in the US, that are better designed, showing all of them similar conclusions, which is better thrombolysis, less time, less thrombolytic dose with no bleeding. This is the ultimate study, the European study, with a rather low number of patients, but still the results were reported recently. Interestingly, there was 0 reports of intracranial bleed or major hemorrhages, and they all show much faster right heart dysfunction in 24 hours with no increase of bleeding risk. Same with Seattle 1 and 2. This is led by a surgeon, Dr. Goldhaber, who actually have a very strong interest in resuscitating pulmonary open embolectomy as a good therapy when applied early to selective patients. But still, with that bias, he actually showed with a bigger number of patients, 100 and 120, that once again the resolution of RV dysfunction was faster with lower thrombolytic dose and no increase of intracranial bleed. So what do we obtain in our center? Well, we accelerate thrombolysis. We rapidly reverse the RV dilation and reduce the pulmonary clot burden, improving lung perfusion and reducing the right heart overload. And we can do this at lower drug doses. Keep in mind that when you actually give intravenous thrombolysis, it's 100 milligrams of TPA, at least in our hospital. This we can do with 20 or less in pretty much all of our cases. Another tool as to why this is important comes with the RV-LV ratio, another index from the radiology colleagues, which is very important tool to have, and we're using this in our hospital. As you can see, there's a line in the intraventricular septum, and then there's a transverse line in the annulum, And a centimeter below the annulum, this is when you're going to calculate the diameter of the left ventricle and the right ventricle. As you know, the left ventricle should be higher, the right ventricle should be smaller, but when this is actually high and the ratio is more than 0.9, that patient is in trouble. And how much in trouble? So much that if the ratio is more than 0.9, this is being shown to be an independent predictor of mortality in the hospital. So how we use that? Well, this study is from one of our colleagues, Dr. Engelhardt at Louisiana. We show that with ECOS application for patients for massive and submassive PE, all patients survive hospital discharge, and there was a significant decrease in the RV-LV ratio and the modified Miller score, again, another parameter, within 48 hours. This is better seen here. You can just see here that the cutoff is 1.9, I told you, significant. You see that all these patients on admission were to the right side of 1, indicating a pretty severe RV-LV ratio. Well, what happens after therapy? This is the predetermined average, and after therapy, those numbers come mostly below the 1 mark, indicating significant reduction of the RV-LV ratio. See, the post-treatment average ratio was closer to 1, but significantly improved compared to the starting point. So at what risk? There was no intracranial bleed, and there's a learning curve associated to this. Initially, the doses of TPA that were used were 45 milligrams on average, and now we have come down to less than 20 milligrams for every patient treated. This is a typical CT scan where you can see the RV much more dilated than the LV, and after therapy, the diameters are pretty close, or even the LV is slightly larger. So much that we have changed our algorithm, and if the patient has compensated shock, but there's evidence of RV dysfunction on echo, we actually, if there's no contraindications to thrombolysis, apply thrombolysis to most of our patients. I can tell you a lot of papers, but I'm going to use the last 2.5 minutes to show you one sample. Like this, we have 15 patients that we're about to report that, with a few differences, they come with a similar severity of presentation, and we have similar outcomes. This lady made it to the local press in our hospital, so that's what I want to show you. She's a 54-year-old, very healthy, and she came to the hospital about a year ago. The only medical history she had was that 10 days prior to admission, she had a pneumonia, which was rare for her, a very active lady, and she was treated as an outpatient in an outside hospital. She goes to Dallas to attend one of her daughter's sorority events. This is a 2.5-hour flight from Tucson. And upon returning, she says that, and you can see here, typically a go-go person, she was wiped out when she got back. I mopped the kitchen floor, I had to take a nap for 2 hours, and that wasn't her. Her husband is actually usually out of the house, but that day he happened to be at home, and also he happened to just be impressed on CPR. So, just to put a personal touch to this story, this is the husband, this is the lady, and she was gasping for air and she collapsed, so Jerry applied CPR for 15 minutes before the paramedics arrived. The paramedics applied an extra 15 minutes for a total of half an hour of CPR before this lady arrived to the hospital. She was intubated when she came to the hospital, and we had a lineup of patients before she arrived at 7 in the morning, and they called us to say, is this a candidate for thrombolysis? So you can see this is straight from the medical record, cardiac arrest. She was intubated, and she was unresponsive, alveolar respirations, weak pulses though. And our question was, did she move the extremities before intubation? They say yes, so we decided to take her to the operating room for thrombolysis. This is the clot. It wasn't a typical saddle embolus, but you can see the tongue of the clot and some clot in the main branches of the pulmonary artery, right and left. And we decided to apply. So clearly she was in the massive PE category. She wasn't minor, she wasn't submassive, she was clearly in cold arrest. So we performed pulmonary thrombolysis. Where did this concept come from? This concept comes from therapy of strokes and applying TPA to strokes. Dr. Tachibana in Japan figured out that applying ultrasound in the skull will accelerate thrombolysis of those little vessels. So this is a clot in vitro, and you can see that with thrombolysis alone, there is some dissolution, but not completely. With ultrasound, of course, there's no dissolution, but with ultrasound and thrombolysis, it's almost complete dissolution of the clot. So this led to the development of this device, available since 1998, but recently approved in the United States for use in the pulmonary artery for a year ago only. So the procedure is fairly simple, and I'm just going to go by because of time. It's placing 2 sheets in both groins, and we can discuss if there's time for questions about the technical details. But the procedure takes about 10 minutes to cannulate both pulmonary arteries and basically dive in 2 catheters. it is important to penetrate the clot with the catheters and not just put the catheter in front of the clot. Putting the catheter in front of the clot is exactly the same as doing intravenous thrombolysis systemically. You have to go through to allow the medication to go in through the ultrasound waves that will dissolve the clot. And so there's, like I said, there's confirmation that you are not through in the lung parenchyma. You want to make sure that you are distal in the pulmonary artery, like you can see there on the left and on the right. And then usually 24 to 48 hours after, you can stop the medication and everything else, follow the hemodynamic response of the patient. So why is it so difficult? Like I said, the fibrin strands are tightly attached to each other, hiding the receptors for plasminogen, and what you do with ultrasound is separating them, allowing the medication to go in, doing this much faster. So we use 2 cc's of contrast, 13 minutes, 48 hours in this case, so a 58 milligram doses of TPA, and this is her. She came dead on April 9. She was given thrombolysis. She was discharged about 12 days after. And this is a clinic follow-up 56 after her death with no RV dilatation, no pulmonary hypertension. Thank you so much for your attention.